So let's start saying that there are, in general, as regards nutrition, there are no specific, the AD-PKD guidelines do not provide specific suggestion for AD-PKD patients, and generally they refer to CKD guidelines. So here a very big tables that resume what we know from guideline as regard nutrition recommendation. As you can see, there are a lot of NR, that is no specific recommendation. And the other recommendation you can see written here are quite similar to those we find from for CKD patients. And also opinion leaders, what opinion leaders say about nutrition in CKD is similar to those two indications for CKD patients. So to help patients, today I try to investigate how can we propose a recommendation for what are the main suggestions we can tell to our patient according what we know today from the literature. And I add something from my experience. So here you see in the first column a list of nutritional items. I divided these items into two groups. So the first group, you can see on the left, can be considered the suggestion about this nutritional item, that is protein, sodium intake, phosphate, and so on, metabolic acidosis control, can be similar to that for AD-PKD patient, CKD patient. And while the items you find on the right, water intake, caffeine, the use of ketogenic diet or calories restriction are more specific for AD-PKD patients. So let's start with talking about the first group. Okay, our population of patients is various because we have old patients with a great prevalence of diabetes, cardiovascular comorbid conditions, sedentary lifestyle. But we also have, and this is the case of AD-PKD patients, young patients with different jobs, with different activity levels. So I think that we cannot talk about the diet for the disease, but the best diet for this specific patients. So the dietitian need to change their approach because the typical dietary plan based mainly on the residual function, even if it is well calculated, because the main problem from dietitian is to calculate the diet, but this is not really the main problem, because this is not enough to improve adherence to the diet. So how dietitian, nutrition need to change? There are no specific rules. The most important thing is to start our approach from the patient and work with the patient and their family to find the best eating style for a specific person. So this is the typical path that a renal dietitian generally follows. So we start from nephrologist dietary prescription, we collect clinical data, then we collect dietary habits. And this is a very important step of our approach, because when we collect dietary habits, we understand, we have more not only information about diet, but also about lifestyle, work, hobbies, activity levels, how the patient is organized in his family, who goes shopping, who prepare food, and these are very important information to for our approach. So this information, together with clinical biochemical information, help us to implement the most suitable dietary intervention. So I listed here some typical situation we can find in our daily clinical practice. We found patients that have a good blood test result with the current diet. So in this case, we don't need to change their habit. But we have also patients with a low food intake, with a high risk of undernourishment. But we also have patients who already follow a dietary prescription, but blood exams are not good. There's not a good metabolic balance, so they need a specific targeted intervention. So generally, what I do in my daily practice, generally I start with an healthy diet. An healthy diet that I summarize in these few simple points. So the first things, I try to suggest the best choices, not to limit patients, and I try to give solution to what I say. So the first thing is to pay attention to salt intake, because this is very important to control hypertension, which is the first, which is very important to prevent a worsening of renal function. So also I tell my patient not to have salt while cooking or eating, but also to limit all the foods which are rich in salt, for example, to limit, not to avoid. I try to work with the frequency of consumption. So those food which are not the best choice, I tell my patient to reduce the frequency of consumption. The third point, have the second course only once a day. So why? Because if patient has a normal renal function, he doesn't need to reduce protein intake. We only try to not to exaggerate, with, especially with animal protein. So this suggestion helps in not exaggerate with protein intake. It is very important to shift the choice of the diet with vegetable, for example, fruits, which is very protective. And another suggestion to use pulses, that is plant-based protein instead of meat, fish, together with cereals, in order to have all the essential amino acids. But this is very important to control proteinuria, to control also another important events that we found in CKD patients, especially those with a reduced function, that is metabolic acidosis. And as you can see, it leads to increased protein catabolism, increased renal damage progression, increased mortality. So it is very important to control these events. So the diet directly affects the acid-base balance due to its composition, because we have molecules with an acidifying action, that is those that come from metabolism of amino acid, in particular those sulfurated amino acid, which we found in animal proteins. But we have also molecules with an alkalizing action that comes in particular from plant-based foods. So and here we try to calculate the potential renal acid load of different kind of diet we can use in patients with PKD, from a normal protein diet or low protein diet, a vegan diet. Low protein diet, we mean 0.6 grams of protein per kilos. Normal protein diet is 0.8. A vegan diet is about 0.7. There are also very low protein diet. I generally use less in my daily practice. But as you can see, the potential renal acid load, which is the acronym is PRAL, is, if it is positive, it means that we have a more acidifying power. If it is negative, the acidifying power is lower. And as you can see, if we use the vegan diet or diet with a prevalence of plant-based foods, the potential renal acid load is very low, and we have a more alkalinesis power. And just to have a comparison, the Western diet, typical Western diet, has a very high protein, a very high PRAL. So it's just so the reduction, so a normal diet is very protective. So I suggest to work on the quality of the diet. It is not necessary to avoid certain food, but we can work, as I said before, on the frequency of consumption and on the serving size. In Italy, we also have this very important tool, that is the protein-free food products, that we use sometimes as a source of green energy. But in a normal diet, 0.8 grams of protein, it's not even necessary to use this low protein food. If we have patients who have a low energy intake, we need to increase the energy density, because if they don't eat enough, the problem is that they use their protein, muscle protein, as a source of energy, and this is not good even for CKD patients. So we need to, for example, to increase the use of high energy food, such as olive oil, or even sugar or jam if there's no diabetes. Or, for example, we use some alternative foods like rice, cheese, or similar, to increase the variability of the diet. We can also use specific supplements if necessary. We have to pay attention that they don't substitute food, so they must be used as a supplement to food. If we have a patient that already follow a diet, but his or her exam is not good, we cannot repeat all the best things it can do, but we need to do a targeted intervention on the basis of blood exams. So if it has an elevated high urea, we can work on animal protein intake. We can suggest to prefer plant-based protein. So, but the important is to use a targeted intervention on the basis of blood exams. We can also use some tool with images which are more easy to understand. For example, if we give a suggestion together with imagery, with a leaflet, with colored images, it is more easy for the patient to remember at home what we say, because sometimes words are not remembered at the same way. So with this simple suggestion, we help to, we gave information about all these items. But what about these other 3 items that are more specific for AD-PKD patients? Okay, here we have a simplified scheme about what happened in AD-PKD. Where does water intake act? It acts inhibiting vasopressin, which generally stimulate CAMP that is connected, as you can see, on increased fluid transport into the cyst and increased cell proliferation. So what about water intake? Guidelines suggest to, as you carry AD-PKD, suggest to drink fluid to satisfy thirst, because there is no evidence that high fluid intake is beneficial for reducing cyst growth. While these 2 authors recommend moderately enhanced hydration over 24 hours with the aim of maintaining an average urinary osmolality less than 280 milliohms per kilo to keep vasopressin secretion suppressed. So there are 2 ongoing water intake trials, the DRINK feasibility trial and the PREVENT AD-PKD trial, PKD, that are investigating the feasibility, compliance, and the impact of the effort of increasing water intake. So we are waiting for these 2 important trials to give more correct suggestion to our patients. At the moment, currently, the suggestion that water intake should mainly be driven by thirst seems to be the more appropriate, in particular in those patients which are following which are with a reduced kidney function, because in this case, drink a lot is not appropriate. And obviously, a very great water intake is needed for those patients who are following therapy with tolvaptan. But for the other patients with a normal function, we have to wait for more suggestion for the literature. Okay, what about caffeine? Caffeine acts at this level, so stimulating CAMP concentration. So it's increasing these 2 points, cell proliferation and cyst growth. What about caffeine? So we have a retrospective analysis on a retrospective study, the CRISPR cohort, which was conducted involving 239 patients. And this study showed there was no significant association between caffeine consumption from coffee, tea, or other beverages with caffeine on progression of age-adjusted total kidney volume, on measured glomerular filtration rate, on time to start dialysis, or that. Another study, the Swiss prospective studies, which was conducted between these years, they show that there was no statistically significant differences in total kidney volume adjusted for weight or estimated glomerular filtration rate between coffee drinkers and no coffee drinkers. Here we have no idea of how the amount of caffeine in coffee drinkers. So what can you say? Okay, the guidelines about caffeine intake are quite, as you can see, the KDIGO say to avoid high caffeine intake, but we don't know what is high. And here we have to say, here we have the suggestion to control caffeine intake. So if we, there's not a specific recommendation. So here we have the content of caffeine in different kind of coffee, espresso, coffee made with mocha, American coffee. So the more appropriate suggestion at the moment is not to have more than 2-3 coffee per day, but remember to pay attention to different food, or for example, energy drinks that have a high content of caffeine. So the problem is not with coffee, but with all drinks containing caffeine. So the scheme now is more complex. So what about ketogenic diet, fasting? That our patients are, there are many questions about from our patient about these new for ADPKD dietary manipulation for our patient. And some patients started to do this diet by themselves. So what about this diet? Okay, they act here on mTOR, on glucose availability, on anaerobic glycolysis, that are very important for sister cell metabolism. So they act inhibiting these two steps. So they seem to be potentially useful for our patients. But what we know about that? Okay, we know that cyst cells metabolism depends on anaerobic glycolysis and on glucose availability. It has been shown that high-fat ketogenic diet led to strong ketosis and to beta hydroxybutyrate, that is a body ketone body elevation, and slowed disease progression with a reduction in kidney size, proliferation, and fibrosis in a rat model of ADPKD. Cyst cells are unable to switch to the use of ketone bodies and fatty acids. They cannot use this substrate, these full sources for their metabolism. So this seems to be an opportunity for patients with the ADPKD to reduce cyst cell metabolism and their growth. As regards calorie restriction, the point is that also calories restriction drives to ketogenesis, and it has been shown to reduce renal cyst growth and fibrosis in a preclinical, so in an animal model of ADPKD. It has also been shown that mild to moderate food restriction, so it means a reduction from the 30 to 50% of energy intake, slow the course of the disease in animal model without causing malnutrition. A 40% reduction of food intake in a PKD1 deficient model animal model, again, it has been shown to reduce kidney size by 50%, decreasing the cystic index, inflammatory infiltrates, and fibrosis. So, and a mild reduction in food intake, 23%, slowed the disease progression, again in a mouse model of ADPKD. So the problem is that all these results come from animal model. We are waiting, and I'm very excited to listen about Professor Mueller presentation, because I hope, because he has two trials ongoing on ADPKD patients on using keto diet and fasting. So I'm very excited to have news about this study to answer my patient who asked me if it's useful or not using fasting or keto diet. It's quite difficult these are two very important opportunities, but I hope that patients start to do this diet manipulation, not by themselves, but asking to their nephrologist, asking to nutritionists and skilled nutritionists, because these two dietary manipulation are very need to be strictly monitored, because a reduction of calorie energy intake of 20, 30, 50% must be monitored. So we have, as regard PKD, we have information from unknown PKD animal model of patients. We have information about animal model with PKD, but as you can see, we have little information or no information about this, the application of these two dietary manipulation on patients. So the fact that ADPKD diagnosis can be made even in absence of renal function decline offers the important possibility to act in a preventative way with a specific dietary manipulation, independent from the classical protein intake restriction typical of advanced CKD stages. So what I can suggest is I prepare this flow chart to help patients in what it's better to do. It's what is the best things to do as regard diet. I suggest, if we have a normal renal function, first of all, start with an healthy, balanced diet with salt restriction as the first point to do, the first recommendation to follow, and together with personalized physical activity program, which is very important to have a very good lifestyle to prevent complication of any kind. On the basis of the results of clinical trials, we can also hypothesize to use ketogenic diet or fasting. We need more data from the literature. If we have a reduced renal function, I think the first step is to start with an healthy, balanced diet, as I said, for normal renal function, and then to have specific recommendation on the basis of medical data, of biochemical data, to prevent or correct the signs and symptoms of uremia and to guarantee a good nutritional status, together with a personalized physical activity program, because it's very important to control weight, to control hypertension, and to prevent comorbidities. With all these steps, it is very important a regular follow-up of biochemical data, of nutritional status. So I think that dietary therapy is a very important therapeutic option in patients with ADPKD. A key issue with dietary management of the disease is compliance, is adherence to our prescription. So to get the best adherence, I think it's very important to start from the patient and work with the patient and his or her family to give solutions instead of prohibition, to find strategies to create a new eating style that not necessarily should be the best of the perfect, but something that our patient could follow easily. So this is why we work a lot. I work a lot with recipes as an educational tool. I use recipe to give solution and to educate patients to find the best eating style. I promote physical activity, which is very important to patient to feel better. So if a patient feels better, he is or she is more prone to follow our suggestions. It is very important a regular follow-up, especially with certain kind of diets. And I think it's very important to keep in touch, to be present with our patient, or in order to answer any question. And this is, I think, the best way to improve adherence to our prescription. Many thanks for your attention.
Thank you very much, Claudia. That was a very clear presentation. Okay. So we've had a number of questions and we've got some time to answer them. I'll try and group a few for you.
Okay.
If that's easier.
Yes, I try to.
So I'll ask them in English,
okay.
And then if you could reply in English,
yes,
that's helpful for the translators. So
yes.
we had some questions about protein, and with reference to the recommended protein
intake.
Okay. 0.8 per kilo, and what is harmful about excess protein. And also, should you spread your protein during the day?
Okay. As I said before, if we have a normal renal function, it is not necessary to reduce protein intake. But in general, I suggest not to. But this is something correct for all the people. Not to exaggerate with protein intake, because it can increase kidney work. I told my patient that we have to help our kidney to work. If we have a kidney failure, so the kidney is not able to remove urea that comes from protein metabolism. So if we have a normal renal function, we have to at least maintain a normal protein intake. But if we have a reduced renal function, it is important to not to exaggerate. And the 0.8 gram for protein is a good start. Then if renal function is lower, we have to think about reducing protein intake. That means to 0.6 or 0.7 grams of protein per day. If we use plant-based protein, they help kidney because they reduce hyperfiltration. So it's very important for example, when we have proteinuria, because if you use with the same amount of animal protein or plant-based protein, the same amount, we can see that with plant-based protein, the proteinuria decrease. So they have they are very helpful. And generally, I tell my patient, as I said before, to use protein in once a day. Why? Because we have the serving is more satisfying. If you divide the serving of protein in 2 serving, is more satisfying, is less satisfying. So I suggest this, but it is possible also to have the source of protein in 2 serving. It's not a problem. The problem is when patients say, okay, it's too small, and they have more. Or sometimes it also happens that patients prefer not to have protein because it's too small, the serving is too small, and this is not correct. Okay, so this suggestion to use protein once a day is more satisfying from a practical point of view.
Very interesting, thank you. And we had a follow-up question about weightlifting. So if somebody is a weightlifter exercising with weights, do they need
weightlifting? Sorry?
With weights?
No, okay. No, I suggest exercising to all my patients independently from, because I try to find solution. If patients have some problem or different age, I try to find solution to adapt physical activity. The only physical activity I don't suggest is weightlifting, because it can increase arterial pressure. So it's not indicated, it's not recommended. And we also, in the case of ADPKD, it is very important also to pay attention to those activity we can cause what's in English?
Cyst rupture.
Okay, yes. I think to pay attention because
okay.
It could be a problem.
Thank you. We have questions about water. What's the right amount, or should one just drink to thirst?
Okay, this is okay. If we are waiting for the result from these 2 big trial, because the previous study are not so homogeneous as regard water intake, because what seems to be important is to have osmolality lower than 280, because in this way we act on vasopressin. And as you can see, you can see in the scheme before. But we have no data so strong to give the recommendation of drink a lot. Obviously, if we have patient with using tolvaptan, here we have the need to drink a lot, even 4 liters per day, because tolvaptan causes dehydration. As regard patient with reduced kidney function, it is important not to drink too much. The correct suggestion is to drink on thirst symptom, waiting to satisfy thirst, because it's the only way to be sure that the kidney has done its work and is telling you that, okay, now you can drink. Because if renal function is reduced, the kidney is not able to manage big amount of fluids. So we have to distinguish on the basis of renal function, okay?
Thank you. We're slightly running over, but there was a question about non-meat proteins and vegetable proteins such as legumes?
Okay. I use a lot vegan diets because, as I said, I said before, they have a more, they help the kidney to work less. So as I say, tell about, for example, the most interesting data is on the effect on proteinuria. In fact, for example, in proteinuric patient, generally we use a vegan diet. So without animal protein, only with plant-based protein. We have to pay attention because plant-based protein do not contain all the essential amino acids. So those we are not able to produce. So we need to, as regard essential amino acids, we are forced to introduce with diet. But we can, overcome this problem, having together protein from legumes or pulses and together with cereals. So in this way, they complete each other. So we can have the same amount and the same quality of proteins from animal. If a patient decides to follow a vegan diet, he or she must pay attention on iron intake and vitamin B12, because vegan diet cannot because plant-based food has not an adequate content of vitamin B12 and iron. Okay, plant-based food have iron, but it is not bioavailable for us.
Thank you. There were some ketogenic questions, but we'll leave those till later in the research session.
The patients can have vinegar. I saw some patients ask this question. Vinegar is allowed.
Vinegar is fine. And also tea with caffeine is?
Yes, I suggest not to to control tea and coffee intake because of, not because the effect of caffeine I described before, but for the effect of caffeine on hypertension. So because to control hypertension is very important for kidney, as a kidney protection. So not to exaggerate. The red tea is without caffeine, so it could be a solution.
Okay. Well, thank you, Claudia. Thank you so much. Thank you, everybody, for being with us this morning.